bi-monthly, and I'm excited to have everyone join us in the room. We're going to get right into it while we wait for other healthcare workers and providers from the other facilities to join us. But I'm delighted to announce that our speaker is in the room, and we're excited to get started. So today's session is on managing diabetes in pregnancy, enhancing better care outcomes. As an overview, we will share more about the Digital One project and all of that as we go along, but just a quick run through of our discussion points for today, our agenda. We will kick off with introductions and guidelines, and I would like to encourage everyone, if you've joined the session already, please introduce yourself in the chat. Let us know your name, the name of your hospital or facility, where you're joining us from. And if you have other healthcare workers who want to join this session, all well and good. We're excited to still have them join. Please share the registration link, not your own link, with them so they can register. We will also share a YouTube link for them to join via the live stream and also be a part of the session. And we're happy to also share the pre-test and post-test quiz for them so they can also fully participate in this session, okay? So we're delighted as well to have the Honorable esteemed Dr. Veronica Iwayemi, who is the Lagos State Primary Healthcare Board Director of Medical Services, Diseases and Control, in the room with us today. She'll be giving us the goodwill message. In fact, I'd like to say she was so excited. She took out time from a very busy meeting. She had an in-person meeting, but she took out time. And she joined the meeting before almost every one of us. She was pretty early. So we welcome you and we really appreciate you, Dr. Veronica. And after that, we'll take a pre-quiz test. So remember that it's very important for us that as we're democratizing this learning, as we are sharing, as we're building our capacity, we're also measuring our knowledge gain. We want to see how these sessions are, you know, empowering our knowledge and empowering our ability to deliver quality care. So following that, our speaker, who is ready to give us this didactic presentation, is a seasoned obstetrician and gynecologist consultant. And following that, we'll take a case presentation. We'll get our speaker's expert insights. We'll give some room for questions and answers. Take the post-quiz quiz again, and then we'll wrap up the session. So we are in for an exciting moment, I assure you. I want to encourage you to please make sure that you're participating, asking your questions. You know, just make sure that you're taking notes if possible. You are fully around or fully present in the session. So as an overview, like I mentioned, Digital One Project is building the capability of women of reproductive age, empowering them with the tools, with the technology, that they need to build their physical well-being, build their self-efficacy, manage their finances, build their resilience, right, and make informed health decisions. And so we are delighted to be partnering with amazing about 34 project facilities in Lagos and Ekiti who are tirelessly, you know, working to improve these quality outcomes for the women that we serve. And we're excited to have representatives on the call today. Next slide, please. Awesome. So a quick run through of our primary objectives on this project. We're providing comprehensive support to boost, just like I mentioned, the physical, emotional, and financial well-being of the women that we serve and their babies. We're also leveraging artificial intelligence-powered solutions to drive digital literacy, improve the ability of, you know, augment human coaching support, virtual coaching support, and also improve women's ability to access care, get answers to their questions, you know, safe, empathetic, accurate questions, contextualized answers as well to their questions. Not only that, we established a virtual learning network on this project, of which many of you are present and are already fully a part of what we are doing, you know, implementing a capstone project, addressing the drivers or primary drivers of preeclampsia, eclampsia, and also just driving quality improvement in your various facilities. We're excited that you joined the call today once again to build your knowledge and your capability. And then lastly, we're empowering women's voices. We're amplifying their voices, educating them on the importance of living reviews, honest reviews on their experience of care so that we can further drive these facilities. So a quick snapshot of our participant learning sites across Lagos and Ekiti states, both private and public. I want to acknowledge everyone in the room today. We welcome you. We thank you for taking time out of your very busy schedule to be here. Also acknowledging our subject matter experts who in the past have contributed to knowledge sharing. If you're in the room, we celebrate you. I want to see some claps in the comments. We thank you for always contributing to knowledge sharing. We're excited. Quick housekeeping rules. I just want to reiterate that because we leverage the ECHO model for delivering our sessions, we're intentional about collecting specific data around your registration, your participation, and we want to let you know that this data would only be treated by authorized personnel and only be used for improvements, for quality assurance as we go along. Also noting that this session is being recorded and we'll be sharing the PDF version of the slides for the session for your continued learning, okay? We'd like to encourage you, please have your cameras turned on. If you have a question, please use the raise hand feature, beg your pardon, we'll unmute you. And feel free to just use the chat function for any questions. Any technical glitches that you have and you need support, our team members are on standby to provide you with that support, okay? But I'm just going to, before we go right into it, it's important that I always introduce who MDoc is because we have some new faces joining us today. Who are we? What do we do? What are we having this session today, okay? So quick overview, MDoc Healthcare is a digital health social enterprise, and our primary goal is optimizing the end-to-end self-care experience for people who live with either chronic health diseases like diabetes, like what we'll be discussing today, hypertension, cancer, or person's regular health needs. Our goal is to build their self-efficacy, guide them to adopt the right recommendations, that will improve their care and help them live healthier, happier lives. And we don't just do this without, some I'd say models. We leverage quality improvement, we leverage data, we leverage technology. We're evidence-based and generating. We want to see how we are ensuring that people, especially African healthcare consumers, have the resources they need to live healthy, happier lives. And we do this through our popular approach, the first of which is our flagship Complete Health. It's a coach-led virtual platform where members can get access to coaching support. They can co-design their personalized healthcare goals and adopt the right recommendations across nutrition, exercise, medication adherence, follow-up appointments, and just improve their health and well-being. Okay. Additionally is our Navi Health platform, which is what we call the Google for hospitals, right? It's where you can get access to facilities that are offering the care where you are or near your location. And you can also leave reviews. The same way you leave reviews on Uber or Bolt when you take a ride, or when you go to a hotel, for example, and you leave a review, or in the past, the way you have suggestion boxes in the hospitals, now this is a digital form or adaptation of that. So you can leave reviews on the experience of care, and then the facilities can take these reviews to drive improvements in their facilities. Additionally is our MDoc Quality Network, which is the platform through which we are delivering today's session, right? We're building capabilities of healthcare workers and even the women or the members that we serve, okay, across different demographics. And lastly, to augment our virtual format of virtual facing solutions, we also have what we call our nudge hubs, which are like community centers where members can walk in to get in-person coaching support, get answers to their questions, track their health metrics, and the likes. So we're going to take a quick run through of the Complete Health video demo just to see what it's like in the next slide. Thank you.
Hello, in this tutorial, I'll walk you through the sign-up process on NaviHealth. The first step is to enter navihealth.ai into your web browser. Next, click on the sign-up button you can find below. Choose from one of the options to register either as a patient, facility, or healthcare provider. Input your details. You can use a registered phone number or email address of choice. But please note that using a registered phone number is compulsory. Make sure to create a strong password. Once you have done that, click on the Finish button to be redirected to input the 6-digit verification code. Get this code sent to your email or your phone number and click to verify the button to complete the sign-up process to get started on NaviHealth. Once the sign-up process is complete, search for a healthcare service close to your location, and once the result pops up, you can search for a facility close to your location. Once you search for a facility, you can click to leave a review on that facility. Make sure your reviews are 100% authentic and original. Input a display name which is not your profile, and thank you for using NaviHealth.
Wonderful. Thank you so much. So we're going to go right into it to take our goodwill message from Dr. Veronica Iwayemi. Good afternoon, ma'am. Please just help me confirm that you can hear me. I'm going to try to Um, Dr. Wayne, please can you confirm that you can hear me? Okay, I think we'll probably come back to that because I think she may have been probably jumped off by network, or we'll check in and then we can come back to that. All right, so we're going to go right into our pre and post test, and we'll take it from there. Dorothy, over. Thank you. All right, as I shared in the beginning, we'd like to encourage everyone to please participate in the pre-test quiz. If you're joining us from YouTube, we would also be sharing these questions for you via link. Akimali, please just kindly provide that support. We'll also be sharing this quiz for you so that you can participate and be a part of the session. We'd like to encourage everyone. I can see answers coming in already. Please make sure that you are participating in the pre-test quiz. Thank you so much. Wonderful. Please keep your answers coming in. Thank you so much to everyone who's participating. If you're just joining us, we're taking the pre-test quiz. If you're also joining us from YouTube, the link to this form will also be shared for you so that you can participate in the session. Thank you so much. If you're unable to see the pre-test quiz, please look to the bottom of your screen. There should be three dots that signify more. You can click on that to get access to the poll questions, please. Thank you. Well done, everyone. Please keep your answers coming in. Don't worry about the anonymity of your answers are assured, okay? We just want to see how we can measure our knowledge gain after the session. Thank you so much. I see more responses coming in. Well done. Thank you for attempting the questions. If you're just joining us, I see some people just joined the room. Welcome, welcome. The silence is because it's like exam time, right? We're taking the pretest quiz. So I want to encourage you, please participate in the pretest quiz. Try to attend the questions. We'll soon be rounding the session up. We'd like everyone in the room to please be a part of this session. It's also not too late to invite your fellow healthcare workers or your colleagues to join the session. You can either share the link, the registration link with them, or you can share the YouTube link. It will be put in the chat shortly. Akimali, please kindly help me share the YouTube link in the chat so that as many people as want to share with other people can do so. Thank you. Welcome, welcome. I see more people are joining the room. We're taking the pretest quiz. We would like you to also participate and take it as well. Thank you for your responses so far. Please keep them coming in. Perfect. Thank you so much. I see that the YouTube link has been shared in the comment section. If there are people you want to share it with to participate from this exciting session, please do so. More responses. Well done. Well done, everyone. We're rounding this up shortly. We just want to give us time to, think through carefully and put in our answers. I know that this seems like a bit of a one of those, I don't know what it comes across as a tricky questions, most of the options, but I want to encourage you, please give it a trial. We will share the answers to the questions afterwards. Thank you so much. All right, we're rounding this off in the next 2 minutes. So please, just a kind reminder, if you're just joining us, please make sure that you participate in the pre-test quiz. If you've already started answering, we're waiting for you. Well done. Well done. More responses coming in. We're almost there. Almost there. Right, 1 minute to go. Well done to everyone who has responded so far. This is amazing. Thank you so much. Love, love, love all the responses coming in. Just giving a little time for our YouTube counterparts to catch up as well. Please let us know. All right, we're bringing the poll to an end now. Thank you so much to everyone. I'm actually clapping. Thank you for taking the pre-test quiz. We're going to go right into it. But before we go right into it, our esteemed guest who is taking the goodwill message is back on now. So we're going to give her time to join us so that we can so that she can take the Dr. Wyman, please confirm that you can hear me now. Hi, Dr. Wyman. Good afternoon. Please confirm that you can hear me. I think that I see you back in the room now, just to be sure. Okay, I think the network might be having a bit of its time today, problems. We understand. We will try to, yes, we'll try to, probably she can probably take it at the end, I guess, when she joins back again. So we'll move right into it. Dorothy, I think we can move on now to next.
I'm not sure if you
Wonderful.
can hear me.
Okay, is Dr. Iwayemi speaking? Okay, great, great, great. Okay, we can hear you, ma. Please go ahead.
Okay, good. That's good. I do apologize. The network where I am is a little bit fluctuating, and so it makes it a bit difficult for me to log in. But if since you confirm you can hear me,
Yes, we can
thank
hear you.
you. Okay, just a minute. Okay, so good day, everyone, esteemed colleagues, participants of this training. It is a great pleasure that I am able to welcome you to this virtual and very important training. Diabetes in pregnancy, enhancing care outcomes. Now, as you know, we're gathered here because we're united by this common goal to enhance the knowledge and skills in providing for pregnant women that visit our facilities and who are affected by diabetes. So our primary objective is to ensure with this session that we're able to equip all the healthcare workers who are joined on this virtual link with the comprehensive knowledge on diabetes mellitus and gestational diabetes mellitus as well. Our focus is going to be, I'm pretty sure from the lectures we're going to get, on identifying risk factors, effective diagnosis, and of course, management strategies that will ultimately enhance the quality of care that we provide for the women that we serve. I'm particularly passionate about this because at the primary healthcare level, diabetes generally in pregnancy presents unique challenges. And so this is an opportunity given to us to be able to make significant impact on maternal and child health. Enhance this knowledge and best practices, we can ensure that our patients receive the care they deserve, and of course, leading to healthier outcomes for both the mothers and their babies. So I want to extend my heartfelt gratitude to the organizers, NDOC, the speakers who have diligently taken their time out to prepare the lecture slides, and also to all our participants here for dedicating your time and expertise to this crucial topic. Your commitment is development.
Okay, I think Dr. Iwayemi, the network probably just glitched a bit. Can anybody still hear me or her? Okay,
So,
great.
having said that, thank you very much, and I wish us all a progressive session. Thank you.
Thank you so much, Dr. Iwayemi. Dr. Iwayemi is a seasoned public health physician, so you can be assured that all the insights and the to have our backing is a big deal. So thank you so much, ma'am. Thank you for your support in driving, continued health outcomes, particularly in Lagos State.
The network is terrible.
Can anybody still hear me? Please just confirm. You can still hear me?
Yes, Elizabeth, I can still hear you. And I
Okay,
heard Dr. Iwayemi as well.
Okay, great. Okay, great. Thank you, Chair Gozi. So thank you so much once again. I think we're going to go right into it. Our speaker, beat all of us in the room today. He was the most punctual. So we're excited that he's here with us. I'm just going to quickly introduce him and then hand over the mic. So thank you once again, Dr. Bolutife Idowu, for taking the time and the interest in building the capabilities of healthcare workers. We don't take this for granted at all. Dr. Idowu is a seasoned physician, consultant, healthcare system leader, and trainer with over 12 years of experience. He's a fellow National Postgraduate Medical College of Nigeria an associate member, Royal College of Obstetrics and Gynecology, and he became a member, West African College of Surgeons in 2015. He was formerly the clinical director at Reddington Hospital, Lekki, and currently serves as lead consultant, obstetrician, and gynecologist. He has also served as consultant obstetrician at the Nigerian Air Force Mother and Child Hospital, Badagry, where he led health campaigns for the Nigerian Police, Immigration Service, and Navy personnel, educating pregnant women, healthcare workers, and running family planning clinics aimed at driving improvements in care. Who better than Dr. Ido would say to this session? He's poised to take it from experience, across all levels. He earned his MBBS from Ladoke Akintola University of Technology, Ogbomoso, State. He completed his housemanship at the same university and held medical officer positions at Bowen University Health Center, Iwo, Osun State, and Abake Medical Center, Osogbo. He began his residency program at the same university where he earned his MBBS and completed it at the Obafemi Awolowo University Teaching Hospital, Ile-Ife. In addition to his medical qualifications, he has bagged several certifications, foreign, global, national, regional, including Leadership and Management in Healthcare from the University of Washington, USA, a certification in gynecology, ultrasonography, infection prevention and control in maternal and neonatal care, laparoscopy and hysteroscopy certification, to mention but a few. I hope I didn't murder those names. And as part of his commitment to driving improvements in quality of maternal care, Dr. Idowu gives regular presentations at conferences and other academic institutions, contributing to knowledge sharing. Ladies and gentlemen, seasoned healthcare workers in the room today, doctors, nurses, pharmacists, lab technicians, non-healthcare professionals, everyone, please, with an ovation in the chat box, right? Let us welcome Dr. Idowu as he takes his didactic presentation. Good afternoon, sir. Over to you. I'm not seeing the claps yet, so don't you want him to take over the mic? Welcome, Dr. Idowu. Please go ahead, sir.
Good afternoon, everyone. I'm excited to be here. I appreciate everybody that made it here. And let me start by appreciating MDoc for inviting me to take this lecture. I also want to celebrate our Honorable Veronica. Thank you for coming. We appreciate you. And for everyone that made it possible to have this online platform, we celebrate you. Everyone joining, whether from the YouTube or Zoom, we celebrate you. All right, today, let me just quickly go into the discussion for today. It is managing diabetes in pregnancy. And my role today is to improve diagnostic outcome. When we look at diabetes, it's something that many people actually do know. But the unfortunate thing is that the diagnosis is often made so late. And so the problem is already established before the diagnosis is made. So my emphasis today would be to improve on the diagnosis of diabetes, and I'm going to touch a bit on what to do in order to improve the outcome. So what is gestational diabetes mellitus? It's been defined as carbohydrate intolerance of varying degrees, whether it's impaired or obvious or what we call overt diabetes mellitus, and it is first diagnosed in pregnancy or the onset actually started in pregnancy. That is qualified to be called gestational diabetes mellitus. And looking at this, that means almost always all diabetes that we know about will qualify for this, because only very few people know what their status is currently. All right, so next slide. So whether type 2 or type 1 diabetes is newly diagnosed in pregnancy, they all qualify to be called gestational diabetes, but there are true diabetes mellitus that are actually as a result of gestational effect. All right, the prevalence of diabetes is increasing globally. And in fact, if you look at the chart, it's been almost what we call a geometric progression. Look at in 1980, it was about 108 million. And as of 2014, it has increased to about 400 the sad thing is that most of these people who have diabetes, they are in developing countries, low and medium income countries. And another thing is that many of them have not been diagnosed even as at now. And majority of these people are within their reproductive age group. Looking at the chart again, you will see that, I mean, the prevalence, you will see that it appears African is preponderantly blessed with people who have diabetes mellitus. And I'm sure that the data is not even up to date, because if those people who have not been diagnosed in our vicinity, our neighborhood are included, this number will have jumped up. Next slide. All right, so to talk briefly about on the clinical symptoms of diabetes, I'm sure we all know that diabetes, many people who have them don't have any complaint. Some of them will have them, but they are so mild that they don't even know that it is diabetes they do have. Some of them will have increased thirst, polyphagia, polydipsia. Some of them will eat and eat and eat. Some of them will be losing weight. Some of them will just complain of dry mouth. Some of them is just tiredness. Some of them is eye symptoms that will make them to present in the hospital. Some will have recurrent genital swelling, boil in axillary region and pubic region. These are common symptoms of diabetics, but they are not specific. So many times it may be mixed. Some of them will present in the hospital and we may never even imagine that they also have diabetes as underground thing behind their complaint. Other symptoms will be related to the complications of the hyperglycemia that they have. Sometimes they will have bleeding in pregnancy, and you will just treat them as threatening miscarriage. Sometimes they have blighted ovum, and it is as a result of hyperglycemia they have. So there is a common history of recurrent pregnancy loss or even outright inability to get pregnant among those who are diabetic. All right. Some of them will come with organ abnormality when they go for anomaly scan around 20 weeks. That's when you first discover that something is actually wrong. And when you look at them, some of them will have heavy baby, heavier than them, greater than 90 percentile of what is expected for that gestational age. Those may be telltale signs that there could be diabetes mellitus. Talking briefly about pathophysiology, we will notice that diabetes is actually a problem of glucose metabolism. If the insulin that is supposed to manage this glucose is very low in the body, it is called absolute insulin deficiency, and that's seen in type 1. Sometimes the insulin that is produced is actually adequate, but they are not able to work at the receptor level. So there could be problem with sensitivity, there could be problem with its final effect at the tissue level. And so as a result of that, you may have valuable amount of insulin in your body, but it's still not working. And that is why we also call that type 2 deficiency or type 2 diabetes mellitus, or also what we call insulin deficiency, or we also call it decreased insulin sensitivity. Now, the causes of resistance that is specific to pregnancy have been adduced to be related to increased level of hormones such as human placenta growth hormone. Another one is placenta lactogen. We have found that among women who have gestational diabetes, they have significantly elevated tumor necrotic factor alpha compared to the general population. Their values are far higher. And we have also noticed that there is increased progression of resistance as pregnancy continues. So if you start with dose of insulin, for example, of something small at the beginning of pregnancy, by the time you are ending the pregnancy, you will see that that dose will not be sufficient. That confirms that insulin resistance continue to grow throughout pregnancy. Other things include elevated cortisol, elevated progesterone, and estrogen. Next slide, please. All right. So let me talk briefly about diagnosis. Diagnosis of gestational diabetes mellitus, as in time memorial been usually made on the premise of risk factor, which I'm still going to talk about. Some of these risk factors include people who have had diabetes mellitus in pregnancy, people who have had family history of diabetic parents or diabetic sibling. You have had a baby with macrosomia, or has had a baby that has had problem with organs, especially ventricular septal defects and many other cardiac defects, making you to suspect that they can have diabetes. But beyond all this, the new thing to know about diabetes is that all of the women presenting in our clinic should be screened for diabetes, irrespective of whether they qualify to be called high risk or low risk. All right. And the first thing to do is to do routine fasting blood sugar for every woman at contact, or at least anytime you're seeing them in pregnancy, whether they are presenting late or they are presenting very early. That's the first thing. And then around 24 weeks to 28 weeks, it is advisable to do routine screening with OGTT. And the values are as shown in the slide here. Fasting blood sugar of 5.1 and above is diagnostic of impaired sugar. And if it is in excess of that it is in overt diabetes mellitus. You can also use 1 hour postprandial sugar of anything greater than 10 millimole per liter, and 2 hours anything greater than 8.5 millimole per liter. Before now, we were using WHO 2013 that used to say that diabetes begin from 7.0, which is 125 milligram per DL, and that 2 hours postprandial of 11.1 milligram per DL. The problem with that is that a lot of women who have gestational diabetes mellitus will not be picked. Many of them will be screened, but you will say that they don't have values, they don't have value qualifying them to have gestational diabetes because of this grade. And that is why a group of people who are interested in diabetes came together in one of the countries in United States of America and started researching into what can we do, because we noticed that people who have these values of greater than 7, some of them come with sudden IUFD. That means baby dying in the mother, and you cannot explain it. And we noticed that some of them actually show features of elevated glycemic control. And so that gave birth to this particular IADPSG group that says that fasting blood sugar that is more than 5.1 should be considered as already impaired, and that patient should be taken as having GDM, and that of 2 hours greater than 8.5. Now, another thing that was also found was that if the fasting blood sugar is greater than 5.1, and that is the only parameter you are using to test, you might actually miss more than 50% of those who need intervention. Next slide. All right, so prior to now, many years back, I think in 1960, Carpenter made a declaration that, for you to make diagnosis of diabetes in pregnancy, you must use certain criteria. But we looked at those criteria. They were criteria for everybody. They were not specific for people who are pregnant. And then in the recent time, after the review of APO trial, which was published in 2008, it was found out that many people who are ideally supposed to have been treated have been missed out if that is actually considered. So the new criteria says that you do not need to wait for 2 abnormal values. So if you have abnormal value in your fasting blood sugar, it is enough to make a diagnosis of GDM. And if you have just 1 hour alone is available, it is important to make diagnosis of GDM. If you make your diagnosis based on 1 value, you might be able to get up to 16.7% of women who are attending our clinic currently. But if you are just looking for 2 values, you will end up having just about 9%, and that will miss a number of people who would have needed our intervention. I've mentioned this risk factor, people who have BMI, those are people that can also present with features of diabetes mellitus. Yes, next slide. Okay, so what are the complications that are associated with gestational diabetes mellitus or diabetes mellitus generally? For those that will be picked, looking at the definition I gave previously, those who have diabetes before pregnancy, we call them pre-gestational diabetic group. Some of them are not diagnosed before pregnancy, but when you are having contact with them, maybe about second month of their pregnancy, around 8 weeks, you might actually suggest that, oh, probably their diabetes mellitus antedate their pregnancy. Some of them, we have some things that are peculiar to them that are not typical of true gestational diabetes mellitus. Some of them we have anomalies. Some of them we have polyhydramnios. They may have VSD, ventricular septal defect, atrial septal defect. Some of them may even have abnormality. What's this condition? There is a particular transposition of great artery and many other problems with the heart. Some of them we have other problems within the ventricular system, and some of them may even have associated anomalies that may not be only diagnosed among people who have diabetes mellitus. But for other people who have their diabetes mellitus late in pregnancy, they are predisposed to having macrosomia, they are predisposed to having polyhydramnios, and as a result of that, they have difficulty during their labor. Some of them we have unexpected cesarean section because there are no other reason for their cesarean section. And some of them will force their way to have vaginal delivery, and eventually they may come down with shoulder dystocia. They have this head-sparing macrosomia. When you see a baby of a diabetic woman, usually the head is within the normal proportion, but the shoulder is a bit bigger than what is expected. So the head eventually comes throughout the vagina, and the shoulder get trapped behind the pubic symphysis, and that becomes an emergency. So some of them die in this process. Some of them we have what we call air palsy as a result of over cooling of the nerves during the delivery. Clunky palsy, some of them can recover and some of them can be permanent. Humeral fracture has been recorded among babies of diabetic mothers. Some of them we have outright obstructed labor, perineal laceration. In fact, when you hear people have 3rd degree and 4th degree laceration, just look at, is either there is a problem with the aperture or there is a problem with the baby. Maybe it's too big. All right. Perineal laceration is common. Obstetric fistulae, it is another thing that is very common among women who have diabetes in pregnancy, especially if they were not picked before the complications set in. Puerperal sepsis, even after they have delivered, this continues to trouble them. And some of them, we have babies who we have hypoglycemia. Next slide. Some of them we have hypocalcemia. Some of them we have hypomagnesemia. Some of them we even have jaundice that is not expected. And some of them we have childhood obesity. And the unfortunate thing is that sometimes, if these things are not well controlled, these children will also end up having diabetes in their future. And that's why we need to pick these people in pregnancy, at least to reduce the prevalence of this complication among them. All right, what are the treatment options that have been discussed that we need to also emphasize? Most times we talk about exercise in pregnancy, but many people don't make a lot of emphasis on this exercise. I'm going to say that one of the things that is plaguing our planet currently now is inactivity. And we notice that when we exercise, we have been able to increase the sensitivity of insulin in the body. So it makes insulin to work, even though it may be little, but that effect is very profound. All right. So exercise, isometric exercise like running, like having cycling on the same spot, like having swimming, these exercises, at least if a pregnant woman can have that for at least 30 minutes, 3 times in a week, it has been found to have significant impact in improving insulin sensitivity, and that helps them. And when you also see them, you also need to introduce them to dietary control. And this is where many of us have not been doing well enough. Many times the obstetrician or the physician will just say, oh, it's a sugar thing, and we want to jump to drugs. No, when these values are still controllable by a dietary method and exercises, then we should please allow that to happen. And please make sure that we don't manage this patient all alone. Diabetic patient, once you pick them, must be managed by multidisciplinary approach. Sorry, please, something is just obstructing my view here. Okay, so other lifestyle modification may be very important. If the patient smokes, takes alcohol, you may have to take that away. Patient may need to have a diary kept to be able to monitor their sugar. They need to have personal glucometer, though the best is not the glucometer. The laboratory one is actually more acceptable. However, we have been able to find out that regular glucometer that most people will be able to utilize in their homes can have up to very close proximity to laboratory tests. So it can be acceptable if the laboratory enzyme method is not available. All right. Other things that have also been used include metformin. Now, in the recent time, metformin has been used, especially in the setting of people who have polycystic ovarian syndrome. All right. But we have also seen that beyond those people, they also do well. Other people also do well when they are on metformin because it improves the sensitivity. It reduces the resistance to insulin, and that controls their sugar very well. All right. Before now, many people have this fear that, oh, metformin can cause anomalies in baby. But looking at babies of children, of mothers who had polycystic ovary and had metformin prior to pregnancy, and even in pregnancy, we have been able to see that there is no elevated, in fact, the odd rate is very low. So it is something that is coming up, and I think a number of us should consider using metformin in order to be able to control this sugar. All right. Another one is glyburide. Many countries, we don't have this glyburide, but there is this Downy that many people still use. Researches on Downy are not so robust yet, so I will not recognize it as a standard way of managing hyperglycemia in pregnancy. However, if your diabetic patients are not controlled by their exercises and their dietary management, which include taking of vegetables, taking of complex starches and all that, cutting down of calories, cutting down on the number of eating, cutting down on the volume of food consumed and all that. If there is no control, then the best is to actually move into having soluble insulin. Now, apart from soluble insulin that is readily available, there are new formulation of insulin that have been found to have very good effect in pregnancy. Some of them, example is Lispro, insulin Lispro. There is another one called insulin aspart, and all of them have been found to be very, very effective because they can give you rapid control. We do not want anyone to give basal insulin in pregnancy. It is not advised because it increases. Yes, in other people, it might help us to have control, but in pregnancy, it predisposes to some other anomalies, and it's also been found to be associated with episodes of hypoglycemia, which are not tolerable. So please, most patients should not be on that. Another thing that we can do is to give them pre-mixed insulin. Usually, when women who have diabetes mellitus are peaked in the second trimester, most of them may have bad level of sugar, poor glycemic control. All you need to do is to give them what we call glycemic control admission. You admit them and start them on soluble insulin. When you start them on soluble insulin and you start to graduate up, usually in the first trimester, the dose is usually around 0.5 international unit per kilogram body weight, and you continue to scale up. By the time you're getting to second trimester, you may have to scale it up to 0.6 to 0.7. And by third trimester, most times, these doses will not be adequate. So you may have to go to as high as 0.9 international unit per kilogram body weight. When you eventually have the control that you desire, you sum up all the total insulin units that was used to control that sugar, and then you now divide it into two. A part will be premixed, and we know premix is a mixture of soluble and intermediate acting. And so it is better that you give the 2/3 of that dose in the morning as a AM dose, and you give them 1/3 of that as their PM dose, and make sure that while you're starting them on that, you keep them on surveillance. You have to be monitoring the blood sugar, 4-point sugar, 6-point sugar have been used, and all of them have given us very good outcome. All right, next slide. Okay, so what are the things we need to do differently? Like I mentioned previously, it is important from the first contact, we should please screen all patients. Just like you will want to know the genotype of your patient, do fasting blood sugar for such patients as soon as you're having contact with them. Some of them may not have the high risk, and yet they have diabetes mellitus. All right, you also do antenatal routine for them, just like you would do for any other patient. All right, you need to make sure that as soon as you pick them, you refer them to dietitian. There is a lot dietitian has to help her. Most physicians are not specifically trained to undo the diet. You will not be able to do their charting and all that. Please make sure that you make use of dietitian. Most of them may have issues with their kidney function already during your evaluation. So these are things you must check for. Electrolyte, urea, and creatinine, you must check. 24 hours urinary protein, you must check. You must check their highs, knowing whether they have issues with their retina already or they need intervention. So that some of them develop what we call retina detachments in pregnancy. And that is a disaster because it might not be well managed in pregnancy. All right, you need to give them frequent visits, especially when their glycemic control is very poor. You also need to make sure that each trimester you are doing a culture test for them, because some of them will have subtle infections, some of them will have asymptomatic bacteriuria, and you need to do that to diagnose that. Other things you need to do include, next slide please. Other things you need to do includes checking other organs for other things that have been coexisting with that pregnancy. All right, next slide, next slide. Okay, so like I also mentioned, when the proteinuria is getting higher, most times we will advise that you introduce them to anticoagulants. Please move back to the previous slide. All right, so other things you can do in the second trimester is to see them frequently. Previous slide, please. You see them frequently. You also make sure that you do a check of their fundal height. It is advisable you do monthly ultrasound. In our center, we do monthly ultrasound for them. Even for other people, you may not do monthly ultrasound. You need to do your own check. Apart from checking their own the patient diary regularly, you need to be looking at the diary, and then you need to do your own check in the laboratory, making sure that the enzymatic tests also correspond well with their glucometer. You also need to do a lot of, sorry, something is popping up. I'm so sorry about that. All right. You need to optimize their glycemic control so that the risk of polyhydramnios, risk of macrosomia will drop significantly. All right. At 36 weeks, you must have a delivery plan for your patient. All right. At that 36 weeks, that's when you determine, is the glycemic control fine? What is the estimated weight of the fetus? What is the plan of delivery? Where is the position of the placentation? Because all of these will come into play when you need to decide the mode of of treatment. Now, mode of delivery is actually primarily vaginal delivery. The fact that a woman has gestational diabetes mellitus or they have pre-gestational diabetes is not an indication for cesarean section. However, there are things that can push for cesarean section in them. So some of these include those who already have macrosomia, already greater than 90 percentile of the weight that is expected at that gestational age, then you need to plan them for, or they have other things such as placenta previa coexisting with that pregnancy. Some of them will have anomalies that may not be compatible with trying vaginal delivery. So you might need to actually invite pediatric surgical team, and every other one to deliver electively in order to be able to foster adequate and a better outcome. All right. So another thing you need to also discuss at this visit during the third trimester is the use of contraception, because sometimes some of them will not know that it is important. They can use contraception together with their pregnancy care. They need to know that as soon as they deliver, within 6 weeks, they should decide for contraception they want to use. And almost all the hormonal too, they can be safely used in diabetic patients. Some of them can go on IUCD, some of them can go on barrier method, and some of them that have concluded their family size can actually go for terminal method, which I believe we all know about. Now, another question is it possible and is it safe to use tocolytics and use steroid to manage preterm labor? Yes, it is, because the fear is, oh, it's going to cause a lot of hyperglycemia, poor control. Yes, it is expected, and that's why such women, when they have preterm contraction in pregnancy, must be admitted. You cannot manage them as outpatient because of that derangement that can occur during the management of their sugar. The management of their preterm labor. All right. So when you give them dexamethasone or betamethasone, the sugar shoots up. But all you need to do is to increase your insulin dosaging at that period of time and continue to monitor it. All right. In labor, next slide. All right. In labor, on the day of admission for labor, sometimes they present in spontaneous labor. Sometimes we have to do induction of labor for them. And it is advised that no diabetic should be allowed to go beyond 40 weeks, because many of them already have lactic acidosis already. Many of them already have background issues with their fetus status. And so it is important to do CTG. Admission CTG is important for such patients. They need to be well hydrated. Pediatric teams should be well informed and also told them, you need to mention and emphasize to them that the woman is diabetic. If the sugar is not well controlled, it must be emphasized in the consult form sent to them. Hourly sugar is important in such women. They need to be monitored closely, and you need to use insulin pump. In centers where insulin pumps are not available, we can continue to use our GK high solution. We can use insulin dosaging. We are using soluble insulin. We can also use other method that we are conversant with, just making sure that you do not have episodes of hypoglycemia or poorly controlled glycemia. All right. Other things we need to prepare for is macrosomia. Now, something needs to be, I need to emphasize this. Even when there is no macrosomia in babies of diabetic patients, their baby have what I call head-sparing organomegaly. And as a result of that, their shoulders are still big. They are still predisposed to shoulder dystocia, even when the absolute weight is not up to 4 kg. Therefore, you must always have that drill when you have such a patient, that shoulder dystocia drill, how to relieve it. You must have that drill before the patient is ready to enter the second stage of labor. It's very important because you might have that in your hand. Then you also need to be ready for hypoglycemia, both in the baby and the mother. So as you are struggling with the baby, you need to also check the mother, because as soon as the placenta is out, the placental lactogen goes down, the other hormones, the cortisols are going down, and eventually there will be what we call hypoglycemia. And therefore, you need to watch it. That's why it is important to do hourly glucose control in such women when they are in labor. Other things include risk of complications of such as puerperal sepsis, and therefore, whether they have indication for it or not, it is advisable to be monitoring their full blood count, and at the slightest appearance of abnormality, you commence your antibiotics. At 8 to 6 weeks, when you want to discharge them from your clinic, you make sure they do OGTT for those who do not have obvious diabetes mellitus. For those who have true gestational diabetes mellitus, most of them will have resolved. The sugar will have gone back to normal by 6 weeks, and you need to do another OGTT, making 2 OGTT that you must do for a pregnant woman who has delivered. All right. We also need to consider annual diabetes screening, because up to about 40% of those who have gestational diabetes mellitus will have it in the next 15 years. Therefore, you need to emphasize and make sure that you refer them to diabetes screening, to GP, and also endocrine in order to follow up with them. So they need to continue their lifestyle modification, because it helps them to slow down the progress, or they slow down the onset of true type 2 diabetes mellitus in them. And you might need to change their medication to their pre-pregnancy gestational drugs. Some of them are on the oral hypoglycemic agents that are not compatible with pregnancy, but as soon as they have delivered, and if you consider them to be safe with breastfeeding, then you can reintroduce them to it. Most of them will do well with insulin still. Some of them will do well with glucophage that I've previously mentioned. Yes, next slide, please. Okay, so in conclusion, while many of us know what to do to manage diabetes mellitus, our problem currently is the fact that we are not diagnosing them enough. And like I mentioned to you, if you do screening based on high risk alone, you will miss almost 55% of people who actually need intervention. And we have found out that among these people are those who will present with unexplained IUFD. Some of them will have been managed, some of them will have been prevented from having those issues. And it is imperative to emphasize this, that please, apart from the first contact fasting blood sugar that you will do, the next one should be between 24 to 28 weeks for those who have not been confirmed to have diabetes. For those who are confirmed already, you do not need to screen them again. Just continue your care. But for those who are negative at the time of initial contact, make sure that by the time they are 24 to 28 weeks, you do another screening. It is important to emphasize this, that delay in diagnosis is the beginning of failure. Thank you very much. My references.
Thank you so much, Dr. Idowu. Just confirming that you can still hear me. Can you still hear me, sir? Okay,
yes, I can
great,
hear you.
great. I'm Dorothy, over now. All right, thank you so much, Dr. Idowu. I think this has been a very robust and yet very practical. I personally, I was taking copious notes. I appreciate how you broke this down across the continuum of care and made it very practical. Oh, this is something to look out for. This is something that you need to do. And then just emphasizing the importance of early diagnosis, to address some of these delays. So thank you so much, sir. I expect to be seeing the thank yous and the claps in the chat, right? Just appreciating that, Dr. Idowu, for this very concise yet, I would say very, well broken down information and knowledge about how we can improve both diagnostic outcomes as well as, care outcomes in the long run. So thank you so much once again, sir. We will definitely share the presentations for continuous learning, but we'll go right into our case presentation now. And Dr. Uche on the call will be taking this for us. Dr. Uche, just confirming that you can hear me and that you are able to take over now. Dr. Uche, can you hear me, please? Just confirming that you're able to speak.
Yes, I can. Hello,
all right, brilliant.
everyone. Good afternoon. Can you hear me?
Yes, I can hear you.
Okay. All right, so I'll be taking on the case presentation. Next slide, please. Okay, so this particular member that we're discussing today's name is Adebi Oluwaseun, 33-year-old woman, married, Yoruba, and a Christian. Occupation was pension administrator, level of education, first degree. Parity, at this point of when the data was collected, when she was asked, she was gravid at 2/11 alive. Last menstrual period was at 2nd of May 2019. At that point this was collected, and estimated expected date of delivery was at 5th of February 2020. Gestational age as of that period was 29 weeks, 2 days. Next slide, please. So her presenting complaint was glycosuria, puffy face, and bilateral pedal edema. So history of presenting complaints, she presented for antenatal visits, and these complaints were registered. Past medical history, she didn't have any significant personal history of diabetes. Surgical history, she had one previous CS done. Her O&G history, she had one term delivery through CS. No allergies are recorded. She had positive family history of diabetes in her mother. Next slide, please. So in examination, PCV was 34, which was within normal. HIV non-reactive at the time of the test. Hepatitis B not available. Blood group was O positive. Electrolyte, urea, and creatine wasn't available. Urinalysis, she had glucose +1. Genotype AS. On systemic examination, her vital signs were done. Blood pressure was 120/85. Blood glucose was high at fasting, 140.4 milligram per DL, and 2 hours postprandial was 248.8 milligram per DL. Pulse rate was 100, respiratory rate was not available, temperature was 36.7 degrees Celsius. Examination findings, she was not pale, puffy face, and bilateral pedal edema as previously indicated. So the diagnosis was gestational diabetes with background risk factor based on positive family history in her mother. Management, she was admitted by the doctor with the action plan as stated below. She was sent to carry out an electrolyte, urea, and creatinine test to assess kidney function and was placed on subcutaneous Lantus insulin 4 international units daily while being counseled on dietary restrictions. Her fasting blood sugar was conducted every morning and random blood sugar checked in the evenings. So basically, she was checking her blood sugar twice, morning and night. She was also placed on IV normal saline internally. She was then encouraged to keep a fetal kick chart. The insulin was increased to 5 international units on the 16th of January, according to the endocrinologist orders. The baby was delivered at 37 weeks gestational age on the 18th of January because of the present condition. Mother continued with her insulin shots until her random blood sugar was stabilized on the 20th of January, which was 2 days after the delivery, at the value of 6.5 millimole per liter. Mother and baby were discharged at 22nd of January 2020, following stable clinical conditions. Baby's weight was 3.9 kilograms. OFC was 35 centimeter, length 55 centimeter. ABGA score was 9 in 1, 10 in 5. So the status of the baby: active, rigorous, not pale, acyanose, temperature was 35.9, not dehydrated, chest not dyspneic, respiratory rates 60 cycles per minute, breath sounds were normal, heart rate was 158 beats per minute, heart sounds were S1, S2 only heard. The updates: baby had a history of hypoglycemia, which was duly corrected by administering IV fluids, 16 ml of 10% dextrose water starts. Then IV fluids 10% dextrose water, 320 ml, that is 100 ml eternally. Baby had 14 tests of random blood sugar tests. So I'll open the floor to questions and answers.
Thank you so much, Dr. Uche. Dr. Idowu, I think we would like to take your expert insight to the case presentation, your thoughts around the entire process and how we can learn from this case presentation. Thank you so much, sir.
Okay, so looking at the case, I can see we have a good outcome. You can see a gravida, what's the gravida 2 para 1 alive woman who had one previous cesarean section and had a diagnosis of GDM at around 29 weeks. That means she's already in the third trimester when she was actually picked. All right, so it was good that we had a good control with 4 international units. All right, but I think if you had actually, I don't know, I didn't have contact with this patient and it's been a while. Did you actually do all these exercise things that we mentioned and dietary control before you introduced insulin? Because I think insulin of 4 international units is quite low. So that patient should have actually have a good control with exercise and dietary control. I'm just thinking, that's just a thought, you never can tell. You may have some other reasons why you started on your insulin very early. Then I also have this question: why was the baby delivered at 37 weeks, knowing fully well that one of the challenges with diabetic is delayed development of surfactant? All right, and there could be worse, in fact, a poor outcome with transient tachypnea of newborn among them, because their surfactant level may not have been well formed. And we have documented evidences that there are delayed formation of these surfactants before 38 weeks. I just want to know, is there an emergency or there is a pressing need or she fell into labor or something else? I just want to know. I'm curious.
Okay, thank you, Dr. Do. So the data here is not complete, but assuming from the information that was provided, it was more like an emergency where they had to do the delivery. So it's looking more like an emergency CS. Maybe at a point it wasn't controlled, and then they had to do like some level of control post delivery.
Okay. All right. Thank you very much. Let's see questions from other people so that we can then base our discussion on those questions. So,
yes, wonderful. Thank you, Dr. Uche, and thank you, Dr. Idowu. I would like to just encourage, if you have questions, from the presentation today or any other thoughts around this subject matter, please put them in the chat box. We will take them in the order in which you receive them. But to start with, I know we have a couple of questions in the chat box right away. The first question says, question: OGTT or fasting blood sugar levels are not routinely done at ANC. Can glucosuria be leveraged as an alternative option to consider as screening? Will that be sufficient? And is the absence of glucose in urine enough to eliminate the risk?
okay, so at this age and time, urinalysis, that's why it was deliberate. I didn't mention urinalysis. Urinalysis should just be like a second gate. It should not be used to diagnose diabetic. Many of them may not even spill sugar as at the time you are evaluating them, and you will miss them. And if you want to even base your decision on 2 pluses, you know, prior to now, we used to say that when you have fasting glucosuria, it is diabetes. Anybody that has fasting glucosuria is already diabetic. That's not even likely to be a GDM. So as at now, please let us use glucometer if we cannot go and use fluoride oxalate bottle and send to the laboratory. Nobody should base their decision on urinalysis.
All right, thank you so much for that very, succinct response to that question. I hope we've taken that note. Next question says, are there specific drugs to be given to a baby who is born to a mother living with diabetes? So this is, expanding the care from just maternal to neonatal.
So are there specific drugs to be given to a baby born to a mother living with diabetics? Yes, we have mentioned this. There are specific drugs. All right. For those, do you mean a small, the newborn or someone, because baby is actually it's
relative? But I said I'm trying to, maybe sort of infer from this question, perhaps it's referring
to neonate,
a neonate.
Is it just within the age of childhood? Because these are things that will help us to know what exactly you meant. All right. But by and large, I always say that babies of diabetic mothers must be monitored for hypoglycemia because of the drugs that the mother is on. The sugar can dip, and there can be a lot of other challenges in that child. That child can have hypoglycemia, can even have hypokalemia, can have hypomagnesemia. So when you know that these things are possible, you can give them drugs that will either manage that condition or prevent those conditions. So you can give them multivitamin that has calcium. You can also give them foods that are rich in calories at this period of time. You may continue to give them drugs that can also mobilize, depending on the age of the child, that can mobilize glucose out of the glycogen store in the body. These are things that can be adequately administered to those children. And other things that are beyond drug include those children you want to make sure that they are not overfed, because if they have childhood obesity, there is a chance that before they even clock 40 years of age, they will already have overt type 2 diabetes mellitus.
Wonderful. Thank you so much, sir. Another question here is, what could cause a sudden change in blood sugar level reading using an AccuCheck glucometer within the space of 5 minutes? So maybe a rapid.
Yes, that happens a lot. And that is why one of the recommendations is that you should do your analysis of blood sugar with enzymatic method. That means you're going to use an electrolyte, what do you call this machine? Electrophoresis method, using chemistry laboratory equipment to be able to evaluate, because that is relatively stable. When you look at electronic devices, they can disappoint at any time. And it may be a factory error. It can also be a contaminant error. It could also be because the strip is actually expired, or they are mixed up together. Because if you have an expired strip added to non-expired one, there is no way to identify them. All right. These are things that can make you to have wrong results. So when you have abnormally high results, usually it is advisable that you do it 2 or 3 times, or get another machine to serve as your quality control to know that, okay, it is truly high. But if it is high and then you have other signs and symptoms of hyperglycemia, then go ahead and treat. But in this particular instance, it appears is a false positive result.
All right, sir. Thank you, sir, for that clarification. We have another question here. What is the likelihood of a person with, gestational diabetes developing type 2 after pregnancy? What is the likelihood?
I think I mentioned that. So if all what's the right word now? All precautions are taken, the risk can be very low. but it's been found out that up to 40% of such women will develop GDM before they clock 15 years after that diagnosis was made in pregnancy. All right. And so it is important to make sure that you don't just discharge them to go home. Even though the sugar has resolved, keep mentioning it to them. Let them continue their lifestyle modification. Eventually, they may be able to push the age of their diagnosis further than 15 years, and that may be more productive. If we remember Priscilla White classification, this has some prognostic effect in their life.
Thank you, sir. Thank you. I think we'll take the last question so that we can start to round off. This person says, thank you, Dr. Ido, for your lucid presentation. I am a bit skeptical about your recommendation of universal screening in our environment, considering the contextual issues around financial burden, manpower availability to do this investigation universally. So, sir, what are some of your practical thoughts considering our environment?
Right. Yes, so looking at this, if you look at the cost of glucometer, and even in this current economy, you will see that it is not significantly costly. And what we need to do is to factor this in when we are making our antenatal packages. Most hospitals have antenatal packages they sell to women. And this sugar, just adding extra 2 strips of sugar to your test will, let's say, give or take, in Nigerian naira, will not add extra significant burden to the money. And it is far better to actually increase this burden of by, let's say, about 2,000 to 5,000 naira difference than to have an IUFD for things that could have been picked before. All right. For such women who will have a bad outcome, what we call bad outcome in pregnancy, they are babies who already have hyperglycemia, whose C peptide is very high, greater than 90 centile, who's have shoulder dystocia or already have permanent injury because of delivery associated neuropathies. All this can be averted if you picked it very early and the sugar has been controlled. The chance of those macrosomia will have gone down significantly, and such will be beneficial. And sometimes it's even with HMO, it's advisable to always document the differences. So if you have not factored that in before you started your antenatal package, all you need to do is each time they come, you mention to them that this is not a routine test, but it is advisable to you. I'm sure all mothers will go ahead and bring their money out of their pocket to be able to prevent such complications. So I think we should just push it. It's so important that we cannot just relegate it on the premise of financial issues. All right.
Thank you, sir. I think we've come to the end of this. Thank you so much for the questions and answers. We're going to quickly go right into our post quiz. Once again, I'd like to encourage and ask everyone, especially if you partook in the pre-test quiz, it's important that you take the post-test quiz, okay? Dorothy, over. Dorothy, confirming that you can hear me? Okay, great. So our post-test quiz is up. I'd like to encourage everyone, if you're yet to see it, please look at the bottom right hand of your screen. You would see the triple dots that would lead you to where you can find the poll. I would like to also encourage those who are joining us via YouTube. We'll be sharing the link via YouTube for you to take the post-test quiz. Let's keep our answers coming in. Thank you, everyone. All right. Thank you to everyone who's responding. After this very robust, I'll say practical and simplified presentation, I expect us to be, churning our answers in by the second. So I'm looking forward to seeing everyone in the room today participating in the post-test quiz. If you're on YouTube as well, please look out for the link. We will be looking out for this. Thank you so much, everyone. If you're just joining us back, we're currently taking the post-test quiz. Please make sure that you join us, you participate in the post-test quiz. Thank you very much. Well done, everyone. If you're just joining us, please take the post-test quiz as well. We're coming up to the end of our session today, but it'll be very important for us to take care of this part before we leave. So please make sure that you're participating in the post-test quiz as well. Thank you. I see our answers coming in really quickly. Thank you so much. God's will, just confirming, can you see the post-test quiz now? Please check on the three dots at the bottom. Let's see if you can pull up the post-test quiz. Or please let us know on the group as well, and we can provide support for you. Well done, everyone. We have just a few more minutes to go. We'd like to encourage everyone, please, if you started the post-test quiz, please make sure that you started the pre-test, please make sure you take this as well. Even if you didn't take the pre-test quiz, we encourage you to please take the post-test quiz. Looking forward to seeing our responses. Please keep them coming in. Thank you so much. Yes, please, Michael Oyegoke, yes, you will get the recorded version. Thank you for asking. Right, we're doing good. We have 2 minutes left to round up this segment. Please, if you've started, we're waiting for you. If you're yet to start, you have about 2 minutes to run through. So I'd like to encourage you, please make sure that you take the post-test quiz as well so that we can all, learn collaboratively and we can also measure our knowledge gain. Thank you so much. Please keep your responses coming in. All right. I believe that we should be rounding up now, but I see that some responses are still coming in. So I want to extend some grace for 1 more minute. Please, we're looking for you. If you're currently taking the post-test quiz, please, we're about to round up shortly. I saw someone's comment earlier when I closed the pre-test quiz poll that they couldn't finish. So I don't want that to be the case this time. So I'm encouraging you, please, we're waiting for you to round up your answers so that we can bring this to a close. Thank you so, so much. All right, I think that we can safely end about now. I believe we can. I need to be sure that we're not losing anyone. Is it all aboard? Can we end the post quiz now? Just confirming before we put a stop to it. I think we will end this now. All right, thank you so much, everyone, for participating in the post-test quiz. Dorothy, you can please bring it to an end. Thank you so much. All right, Dr. Idowu, we'll quickly run through the questions now and get your answers to them so that everyone on the call can see or can hear and see how they fared in the test. Thank you so much. So the first question is, the pathogenesis of hyperglycemia is in true gestational diabetes mellitus includes all the following mechanisms except A, increased glucose production by the liver, B, impaired insulin secretion and sensitivity, C, increased metabolism, and D, absolute absence of insulin. So what's the correct answer to this question? Okay, I think Dr. Idowu is having a little glitch, so I think we'll just go right ahead and just run through some of the answers until he can connect back. Okay, so the correct answer for this is D, absolute absence of insulin. Number 2, the test for checking mean plasma glucose concentration over the previous 2-3 months is A, hemoglobin A1C, B, OGTT test, C, the fructosamine test, and D, fasting plasma glucose concentration. The correct answer is A. Number 3, the following statements are correct except one. If symptoms of diabetes are florid, OGTT is not needed. Number 2, OGTT at booking and 28 weeks is a standard practice. Option C, OGTT negative patients at booking do not need a repeat test. And D, cutoff value of less than 5.1 mmol is GDM. The correct option is D. Number 4, OGTT for confirmation of diabetes in IAD-PSG is A, 100 grams only, B, 150 grams only, C, 27.5 grams, and D, 75 grams, not 50 grams. The correct answer is C. Number 5, which of the following statements is correct about insulin sensitivity? A, improvement is unchanged with exercise. B, sensitivity becomes worse with advancement of pregnancy. C, glycoside only spontaneously controls poor sensitivity. And D, folic acid, not metformin, corrects the abnormality. The correct answer is B. Number 6, cause of insulin excess secretion in pregnancy is A, increased calorie intake, B, increased exercise, C, decreased adipose deposits, D, none of the above. And the correct answer is A, increased calorie intake. Number 7, we're almost to the end of the questions. About the complication of GDM, which of these is correct? A, macrosomia can occur. B, fetal anomaly are numerous. C, fetal hypocalcemia is common. And D, polyhydramnios can be associated if onset is late in pregnancy. The correct answer is A. Number 8, which of the following statements about OGTT is correct? A, OGTT is not needed after delivery. B, WHO has agreed to high risk screening only. C, the cutoff value of 11.2 is for screening and fasting. And D, smoking a few hours before testing affects results. The correct answer is D. The last, but not the second to the last, number 9, the following can be safely used in pregnancy except A, soluble insulin, B, insulin lispro, C, NPH, D, none of the above. The correct answer is D, none of the above. And then number 10, which of the following is appropriate dietary advice for a patient with GDM? A, low carbohydrates advised. B, patients advised to eat no more carbohydrates. The correct answer is C. I'd like to thank everyone and appreciate everyone who has, taken part in this post-test quiz and has given their responses. I hope that this learning session has been very, very practical, very helpful for us in equipping us and, building our capability to, as Dr. Idowu said, improve diagnostic outcomes, for these cases of diabetes and pregnancy and enhance ultimately the management and the care outcomes for these patients, saving both the lives of mothers and children as well. Once again, I'd like to thank everyone who joined the session. Dorothy, please could you move to the next slide, please? All right, so we're going to quickly take our reaction survey. We just want to measure how this session has contributed to your learning and some of the feedback or improvement that would drive further improvements in how we deliver the session. So please, you could launch the poll, Dorothy. Thank you. Okay, let me see if I can pull that up on my end. Okay, just a slight glitch on my end in pulling this up. Dorothy, please, can you hear me? Are you able to pull this up?
Yeah, the reaction survey is up.
Okay, great.
The results are already
okay, great. I think the glitch is on my end. Apologies. Thank you so much. Right, Dorothy, I'm going to lean on you to just, guide me on when we can end the poll. Apologies for the glitches on my end.
Sure, no problem.
All right, everyone, this is just 5 questions. I just want to encourage you to please provide responses to the poll. Thank you so much. All right, 1 more minute to go, and we'll be closing the poll, the reaction survey. Thank you to everyone who has responded so far. 30 seconds to go. All right, we're going to close this right about now. Thank you, Dorothy. Please, we can move to the next slide. Thank you so much. All right, just one more ask from us. We would like you to please share in the chat box any other topics that you would like us to address in our upcoming sessions. The dedication sessions are very helpful for us in supporting you to deliver improved quality of care. We'd like to remind you, please follow us on all our social media platforms, Facebook, Instagram, Twitter, YouTube as well. Thanks once again to everyone who joined us via YouTube and on LinkedIn to stay abreast of all our updates, our upcoming sessions, and all the exciting things that we are up to here at MDoc Healthcare. Next slide, please. And last but not the least, just reminding us that we'd like to encourage you. Remember that at our last review meeting, we recognized the facilities that were intentionally generating reviews via NaviHealth, and they are getting a gift. So this is an encouragement to all the other facilities. Please leverage the amazing potential of our NaviHealth platform. Profiles have been created for you. Encourage your healthcare workers to, I beg your pardon, encourage your members who are visiting the facility to leave reviews on the experience of care via NaviHealth. And we will continue to, track improvements. Beatrice, I see that you have a question, a comment about the topic, management of hypertension. Thank you so much. We actually had that session in July. So someone will quickly share the link for you right now in the chat, or would encourage you to visit our YouTube to go and rewatch the session. We already had the session in July on management of hypertension in pregnancy, but thank you so much for asking. This is important to us. All right, we'll skip past right this, just reminding us as well that we are promoting the capability and self-efficacy of our members through Complete Health. We'll also put the link in the chat just so that we can encourage your members to download Complete Health and receive access to self-care support that will build their capabilities and overall improve healthcare outcomes. Thank you once again. Heartfelt, unreserved thanks to everyone who joined the session, who participated with a question, who had a comment, who encouraged us, and to our esteemed guest speaker who brought, value-loaded insights for us, practical, contextualized, to help us build our capabilities in, improving care outcomes across the continuum of care, ANC, intrapartum, postpartum, and on and on. We can't thank you enough, so thank you so much, Dr. Idowu. And thank you to everyone else on the call. Thank you for coming. Thank you, Dr. Iwayemi, for that wonderful goodwill message as well. We really, truly appreciate your support, continued support. Thank you so much. And thank you to everyone who's giving us, suggestions on possible future topics. We are happy to take that, into consideration as we prepare future curriculums. And for the slides, yes, you are totally going to get it in your email. So look out for it in your emails. We will share that for you. And yes, please stay abreast of us on social media, MDoc Healthcare, mymdoc.com, Facebook, Instagram, Twitter, YouTube. Thank you once again for coming. Oh, thank you so much, Dorothy, for pulling this up. So before you jump off, you can just take a screenshot, right? So that you don't forget how to locate us on social media. We'll leave this up as we round up the session. Thank you once again. Have a wonderful evening and a beautiful weekend ahead. Bye for now. Thank you.